attach it. Meniscofemoral ligament will be there. So I attach the avulse part as it is now. I don't disturb the meniscofemoral ligament. But most of the times, as you rightly told, the lateral meniscus root, meniscofemoral ligament is very clearly visible. Yes.
So you repair it in situ, or you try to release and try to put it at anatomical position?
I repair it in because lateral meniscus always has one fiber coming from the actual body.
Yes.
So I attach to the actual body to the where it is. The fiber will be retracted. But medial meniscus, whenever it is retracted, there will be a gap. The study shows that you can attach to the gap wherever it is. But lateral meniscus body is there, it will not get retracted. So it is avulsion. Medial meniscus get retracted.
It's loaded there. Yeah.
Dr.
Rajeev.
Yes, sir.
Can I ask
Two
one
to a.
question?
Yes, sir.
How do you differentiate or how do you prevent coalescence of the tunnels between your ACL and the root tunnel? How do you prevent coalescence?
Sir, ACL, if we use root jig for medial side, we can direct it from lateral to medial side. ACL jig anyways from the medial to up to the tibial. Lateral meniscus, some of the papers and suggest that you can use the same tunnel for the lateral meniscus and ACL, but better to use a different tunnel. So with the root jigs, you can adjust the tunnel. And anyways, this is 4 mm tunnel. ACL will be at least 7 mm tunnel. So, for 3.5 or 4 mm tunnel for the root attachment. And that may not be in coalescing with the ACL tunnel.
So the ideal way would be before, when you're doing a root repair with an ACL, before you make the tunnel, have 2 bead pins, one for the root and one for the ACL, and see the distance at the tibial side.
Yes.
And then go in for the
I think that is the best way normally we also follow. So for medial meniscus root tear, try to be your ACL tunnel, root tunnel, try to keep medial. For lateral meniscus, try to go lateral. So that both the tunnels are parallel, it will not collide. And I think the bead pin technique is very good. That will help you out in collision of tunnels. So I will be talking on discoid making for decision making for discoid lateral meniscus. Next slide. Yeah. So normally most of these patients come in our clinic either with a pain, leak, third, locking, or a giving way. Sometimes a large discoid meniscus patient will come to your clinic with a giving way sensation also. Next. So normally, it's working from here. Oh yeah. So normally it may be a symptomatic discoid or asymptomatic discoid. As you know, most of the discoid meniscus are there since the adulthood and childhood. The patient comes to in our clinic only when there is a history of locking episode. So how will you deal with this? So sometimes you can see this is a case of incomplete discoid. You can see the smoothing of the margin. Normally, the lateral meniscus covers 60 to 70% of the lateral tibial plateau. If it is more than that, it's a discoid meniscus. If it's covering whole of the tibial plateau, it's a complete. If it's covering up to more than 70% of the tibial plateau, it's an incomplete discoid. Video, please run. Please run the video. So you can see it's a symptomatic discoid meniscus. There is a tear here, complex tear in the discoid meniscus. To start balancing your meniscus and don't try to use saver, because what will happen, you will not preserve the rib. So the basket punch is the best instrument to gradually you can see and try to find the unstable layer. What happens? You have 2 cleavage there, superior and inferior. Sometimes you have an unstable inferior layer, sometimes you have an unstable superior layer. So with your probe, try to find your unstable layer and balance it. So try to keep at least it. And this basket punch is the best device to balance your meniscus. Start from the center and gradually go posteriorly and anteriorly so that you have a after suturization. So you can see after balancing, you can see again, put your probe inside and see which layer is unstable. So gradually I am balancing it on the posterior side. And now you see with the saver, just take out this debris out and see the upper layer is coming inside at the middle point of the knee joint. So that layer is unstable. Again, try to balance that layer. And this is very important. If you keep this unstable layer there in balancing, when you are doing suturization or balancing of the lateral discoid meniscus, patient will have some amount of instability, click, or locking episode in due course of time. And now you see the inferior layer is stable and you have done a perfect balancing of the discoid, incomplete symptomatic discoid lateral meniscus. So again, for discoid meniscus balancing, always try to use the basket punch. run this video. Normally, we have a straight punch, right, curve to the right, curve to the left, and backbiter. Keep all those 4 sets there. You can see the straight punch, it comes is a straight or a 15-degree up. And you can see this is curve to the right and the curve to the left punch. And keep all these 3 punches ready when you are planning for treatment or balancing or suturation of a discoid meniscus. What happens sometimes when you use saver, most of the time you save most of the meniscus, and sometimes in this patient you come up or you end up doing a complete meniscectomy. Here you can see this is a symptomatic discoid. The straight punch works better in the central part of the body, but because it's that direct, so you can see 15-degree up straight punch, and I am trying to balance the meniscus, just balance it. And you can see sometimes what happened, you can see the tibial spine come in between. What is the technique? Just rotate, and you can see, and again you can negotiate, and you can cut some part of the posterior of the meniscus also. This is the best way. Rotate your 15-degree basket punch down, and you can just negotiate to the tibial spine. Then take your right and left punch to, you can see, this is for the posterior part. You can see balancing of the posterior horn is easy with the curve to the right, and balancing of the anterior horn is easy with the curve to the left. And now you see you have a good meniscus. You can rim there, which you have balanced. If you are using saver, most of the time you cut more of the meniscus there. Now you have to balance the anterior horn. Here we are taking the curve to the left punch, and you can see now I am balancing the anterior horn. So these 3 punches are important, and you can see you have a good stable rim of the lateral meniscus. So incomplete discoid lateral meniscus, don't try to use too much of saver. Try to balance it with your basket punch. Video. Sometime after balancing of the lateral meniscus, you will see you have a unstable rim, outer rim of the meniscus. And studies have shown, the biomechanical studies have shown, if you can preserve this rim also, that will prevent degeneration of the arthritic changes inside the knee joint. So here you can take a vertical mattress suture. You can use any of the self-retrieving suture passing device. And we are using orthocord suture here. So try to take a vertical mattress suture. 3 or 4 vertical mattress suture are good enough to stabilize your rim. And believe me, if you save 6 to 7 millimeter of the lateral rim, that will also prevent degenerative changes inside the knee joint. And try to put your knot toward the capsular side, as we were discussing in the first session, where you should put your knot. So try to put your knot. So first bite, second bite, and gradually you can see whole of your rim is getting stabilized. So after suturation of your meniscus, sometime if you see there is an unstable rim, put 3 or 4 vertical mattress suture. You can use your all-inside device. You can use your self-fitting suture passing device. And you can see as a good rim of the meniscus has been stabilized. And this 6 to 7 millimeter of the rim is good enough to prevent arthritic or degenerative changes inside the knee joint. So discoid lateral meniscus, I think the most important part is symptom. Most of the patient, when they come, it is symptomatic. If there is no symptoms, I think keep them on close follow-up. Yes, if the patient is coming in your clinic with the symptoms of either locking episode or a third, if patient is adult with a complete discoid lateral meniscus, with or without pain, go for a partial meniscectomy, with or without meniscus repair, what we call balancing. At children, usually most of them come with a complete discoid, and mechanical symptoms is there, go for partial meniscectomy, again with or without repair. Adult with incomplete discoid, if they come with pain and with or without mechanical symptoms, go for suturation of the meniscus with meniscus repair. And if there's only click and no other symptoms, keep them for close follow-up. And I think this is the sequence you should follow when you are making decision-making for your lateral discoid meniscus patients, seeing the patients of lateral discoid meniscus. Thank you so much.